Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to another episode of Stay Healthy, where we discuss issues concerning your health. I'm your host, Maryam Salim, and today we're going to address the issue of diabetes. More than 463 million people worldwide are suffering from diabetes, and this number it is increasing at a very alarming rate. Before we continue, let's take a look.
Diabetes is a chronic metabolic disease characterized by the elevated levels of blood glucose, which leads over time to serious damage to the heart, blood vessels, eyes, kidney, and nerves. The most common is type 2 diabetes, usually in adults, which occurs when the body becomes resistant to insulin or doesn't make enough insulin. In the past 3 decades, the prevalence of type 2 diabetes has risen dramatically in countries of all income levels. Type 1 diabetes, once known as juvenile diabetes or insulin-dependent diabetes, is a chronic condition in which the pancreas produces little or no insulin by itself. For people living with diabetes, access to affordable treatment, including insulin, is critical to their survival. There is a global agreed target to halt the rise in diabetes and obesity by 2025. About 422 million people worldwide have diabetes, and the majority living in low and middle income countries, and 1.6 deaths are directly attributed to diabetes each year. Both the number of cases and the prevalence of diabetes have been steadily increasing over the past few decades. The causes are complex, but the rise is due in part to increase in the number of people who are overweight, including an increase in obesity and in a widespread lack of physical activity. But a large proportion of diabetes and its complications can be prevented by a healthy diet, regular physical activity, maintaining a normal body weight, and avoiding tobacco use. In April 2016, WHO published the Global Report on Diabetes, which calls for action to reduce exposure to the non-risk factors for type 2 diabetes and to improve access to and quality of care for people with all forms of diabetes.
Helping me to unpack on today's topic is Dr. Saira Sokwala, Head of Department Diabetes Care Center at MP Shah Hospital, Nairobi. Daktari, assalamu alaikum wa rahmatullahi wa barakatuh, and welcome to the show.
Wa alaikum salam wa rahmatullahi wa barakatuh. Thank you for inviting me.
Indeed, it is a pleasure to have you. Let's start by addressing what is diabetes.
So diabetes is a chronic condition. It's a long-standing condition which is associated with the problem of the body to use sugars. So that is to use glucose, either because there is a problem in the production of a hormone known as insulin or in the use of that insulin. So to understand it better, we need to understand what is insulin. And insulin is like a key. So whenever we take food, it has different components, right? There's the carbohydrates, which are the starches and the sugars. Then there's the proteins, which are the bodybuilding parts of the bodybuilding foods. And then you have the fats and you have the vitamins and minerals, right? So when we take in food containing carbohydrates, there's the sugars, then what happens is the body is, the sugars, they are taken up by the blood around the stomach, and then that goes to an organ which is just below the stomach, which is known as the pancreas, and it stimulates, it tells the pancreas to produce, so the pancreas is like a big factory. So the sugar tells the pancreas to produce a hormone known as insulin. Insulin is like a key which goes with the sugar to the different parts of the body, and especially the muscle and the fat and the liver. They need this insulin to open the doors of the cells so that sugar goes in, and that's how we get energy.
So that can be absorbed.
Yeah, so exactly. Okay. So that's why it is known as energy-giving foods, the carbohydrates.
Yeah,
you know what we have read in biology.
Yeah, true.
That is the truth of it. That's why it's known as, that's how the whole process works. So whenever there is a problem with the factory to produce the keys, that's the insulin, or inability of the insulin to open the door, then what you get is the sugar not being used by the body, so it circulates in the blood, and then that's what constitutes actually diabetes.
Diabetes, okay. So kindly tell us what are the types of diabetes and who is at more risk of having this disease?
So broadly we can classify diabetes into 4 specific types, 4 different types, type 1, type 2, gestational or pregnancy related diabetes, and then the other specific types. So the types are best understood by understanding now that mechanism that I told you about, the effect of insulin being produced or action of insulin. So type 1 diabetes is when the body cannot produce insulin at all. So the factory that produces insulin or those keys is shut down completely. It is due to your body's own immunity going and destroying, which is known as autoimmunity, destroying that part of the pancreas which produces insulin. Why exactly that happens, we don't have clear answers. It could be a genetic predisposition or some environmental factors. Some foods have been postulated like cow's milk, but that's not 100% clear on why it exactly happens. Usually affects about 5% of all the people living with diabetes, and usually affects younger individuals less than 30 years of age. So in this case the person, it depends on insulin for survival. So now because this type of diabetes is associated with no production of insulin or really very low production of insulin, there is no specific risk factors that are known for this particular type. So it's not as yet a preventable type, although a lot of research is being done in that area. The most common type is the type 2 diabetes, which affects about 85 to 90% of all those people living with diabetes. This is the one which is mainly associated with the lifestyle factors that we talk about and potentially could be preventable, although not 100%. So type 2 diabetes, we used to think that it occurs in older people, and generally older people are at an increased risk, but now we are seeing it occurring even in very young individuals, even up to the age of 15, 16 years we have seen having type 2 diabetes. The point is that these are individuals who have, like the risk factors, when we look at it, it is, you can say they are modifiable risk factors and non-modifiable. Like non-modifiable is something you can't do anything about. Like if you have a family history of diabetes, or you have a high risk, you are in a high risk community.
So you can inherit it from your parents.
You can inherit it. Actually, if one of your parents has it, you have a risk of 25% of getting type 2 diabetes. Yeah, and it runs more in families. So people have stronger family history than even with type 1 of diabetes. Then so these are the non-modifiable risk factor, and then increasing age, like we said, is another risk factor. And then when we look at the risk factors which we can do something about, or which are the modifiable risk factors, then we look at obesity or overweight being amongst the highest on the top on the range as risk factor, which modifiable, right? You can do something about it. Or the other risk factors is a poor diet, like your diet being high in calories and high in carbohydrates is a high risk factor, which we see nowadays. Yeah, all our foods you can see is, we have a lot of people have moved to fast food.
Yeah.
Like in town, everywhere you go, the smell you get is
and it's also
amazing,
cheap.
you know.
Yeah.
Yeah. So it's cheaper, it's more available, and everyone is going for that. It's more palatable, you know. It's and it's being advertised quite
Everywhere,
a bit,
yeah,
you know,
true.
everywhere. Then the other risk factor is lack of physical activity. So you can see nowadays the kind of lifestyle that people have adopted. That's why, like you said very nicely, the numbers are exponentially increasing. So it's actually 463 million people, out of whom imagine 85 to 90% have type 2 diabetes. And that's why the numbers are increasing, because the main increase is in type 2 diabetes. These numbers are actually expected to increase to above 700 million by the year 2045. So we're expecting a really huge increase, and mainly due to the increase in type 2 diabetes. So when you look at physical activity, what I was saying is, you know, this sedentary lifestyle that we have adopted nowadays, where you're waking up, you're getting in your car, you get to your office,
You get to work, you sit down the whole day. Yeah,
you're in
true.
front of the computer, or otherwise mostly sitting jobs. You are going home again in your car.
You're using the lift.
You are
in
using
fact.
the lift,
Exactly.
right? You're
No
using the
stairs.
lift, no stairs. So you're going down, sitting in your car, getting home. See, of
Sitting
course, you're
on your
tired,
sofa.
right? You're tired.
Exactly.
So you'll sit on the sofa, you watch your telly, yeah, and the day is over, you know. So that kind of sedentary lifestyle is what has brought us a very high risk of not only diabetes, but other heart and blood vessel problems like heart attacks and strokes. It's a very high risk factor. Then other risk factors are like smoking. It's also a big modifiable risk factor, which we can do something about, right? Other risk factors is that like the sedentary lifestyle overall, what I talked about, right? And then the other risk factors like some medications also can predispose to developing type 2 diabetes, like medications used for depression, or some medications which are like steroids, they can also predispose you to develop diabetes, okay? Then we have the third type, which is not as uncommon, I should say, that's the gestational diabetes. That is pregnancy related and due to pregnancy diabetes that comes in. When a woman becomes pregnant, the hormones that are produced by the, the placenta, the placenta that hosts the baby, that is actually, those hormones, some of them are quite diabetogenic, that means they can predispose to diabetes. So that is known as gestational diabetes. So generally about 1 in 6 live births have diabetes, yeah, and out of whom about 86% have gestational diabetes. The remaining, of course, is the diabetes that was there before pregnancy. And this type of diabetes puts women at increased risk of developing diabetes even later in life. About 50% of them go on to develop diabetes in about 10 years or so. So it's a big risk later on. Then we have the other specific types, the fourth category, yeah, whereby you have got conditions like hormonal problems, like women who have polycystic ovary disease. Maybe you've heard of polycystic ovary disease. It's a problem where women have issues with their menstruation, they have excessive body weight, excessive hair growth on the face, and areas where it shouldn't be, acne, excessively. So that condition also predisposes them to develop diabetes type 2. It's more like type 2 diabetes, but it can be pre-diabetes as well, like which is borderline, okay? Then you have other hormonal problems related to, excessive production of certain hormones, like there's a hormone called cortisol, which is actually the stress hormone. But when produced in excess, it can actually increase the sugars and predispose to diabetes. Then you have got other conditions like genetic forms. There are some specific genetic forms which are related to getting diabetes, like even in newborns. There's a specific type of diabetes known as neonatal diabetes, which can occur in newborn babies.
They carry it from their mother, they got it from their mother?
It is genetic related, okay. So they get it as you can't say specifically inherited trait, but basically due to the genetic modification that has happened in their body, and they develop this type of diabetes. It's known as neonatal diabetes. Yeah? So these are the broad categories of diabetes.
You mentioned quite a few types of diabetes, but let's talk more about gestational diabetes. You have said that the mother develops it once she's pregnant.
Yes.
And there are chances that she may continue having diabetes even after giving birth.
True.
What about the child? Could that child also be affected?
Yeah, that's an interesting question actually. So children of mothers with who have gestational diabetes have been shown to be at increased risk of even obesity and type 2 diabetes later on in life. So studies more and more are coming out because now we have got long-term data available. Yeah? And it is true that those children also do stand a higher risk of developing diabetes later in life. It's true. Yeah, so gestational diabetes, in fact, like while we are at the topic, I would like to take this opportunity to just, sensitize the viewers that this is a condition which, yes, it can occur to any woman who conceives, but there are also some specific risk factors which predispose you to develop gestational diabetes. And those are the risk factors which we try to advise patients to control before they become pregnant even, yeah? Like the same risk factors that stand for type 2 diabetes, like overweight or obesity. Women who are overweight or obesity have a higher chance of developing gestational diabetes. Those who have a family history. So those are the patients who need to actually, the individuals who need to test their sugars earlier in pregnancy. And because they do stand a high risk of developing even diabetes anyway, and so they are at much higher risk of developing gestational diabetes. Also those who have had a first degree relative who has diabetes, or those who have high blood pressure, or those who have cholesterol problems, all these individuals stand a high risk. Even the polycystic ovary patients, they do have a high risk of developing gestational diabetes, okay, even if they didn't have diabetes earlier.
Well, okay, Dr. Let's take a short break. When you come back, we'll take it from where we left. Stay tuned. Assalamu alaikum once again. Welcome back to Stay Healthy. This is our second part of the show. If you're joining us, we are talking about diabetes. Before we went for the break, Daktari was telling us more about gestational diabetes. Daktari, welcome back once again. When we went for the break, you were telling us more about gestational diabetes. Maybe you can take it from there.
Yeah. So what I was saying is that I'd like to take the opportunity to sensitize all the women out there. Yeah, if you have a risk factor, like I mentioned, the risk factors that I mentioned, being obesity or overweight, having a family history of diabetes, having polycystic ovary syndrome, or having high blood pressure or cholesterol problems, then you need to actually get your sugars tested earlier on in pregnancy. But generally, if you don't have those risk factors, then we advocate that every woman who is pregnant, and this ideally is supposed to be universal, should go for this test known as the oral glucose tolerance test to assess for gestational diabetes between 24 to 28 weeks of pregnancy. So that's something very crucial, because you can easily miss out, because gestational diabetes may not come with symptoms. Yeah? So then you need to screen it actively. And the truth is that once the pregnancy is over, so you'll be put either on lifestyle modification, like diet and exercises, to try and control your sugars, or you would be put on tablets or even on insulin, the injectable forms for some women who need it. Many women actually end up needing insulin, and that's the safest to give in pregnancy related diabetes. But after delivery, most of the women, these sugars, they stabilize. They become completely normal and they don't need medication. But remember that you stand a high risk of developing diabetes later. So at about 6 to 13 weeks, we advocate that these women actually get the glucose tolerance test done again. It's not a difficult test. You just go in the morning fasting to a lab.
Before taking breakfast?
Yeah, before taking breakfast.
Okay.
You are checked your sugar before taking the glucose. You are given some sugar, to drink, some glucose to drink. Then 1 hour and 2 hours later, you are checked your sugar. So it's as simple as that. Okay, but it can actually be life-saving to the baby, and also it can be protective to the mother to prevent complications of pregnancy, because it is related to serious complications if it is not
checked earlier
and managed accordingly.
Okay.
So at 6 to 13 weeks, you need to check the glucose tolerance test again, and then every at least once or 1 to 3 yearly, they need to be checked for diabetes later in life.
Thank you, Daktari. But you have mentioned you have talked about sugar levels to be checked. So once you are diagnosed that you are suffering from diabetes, so how often should your blood sugar levels be checked?
Yeah, so it depends on the type of diabetes that you have and the kind of medication that you are using for diabetes. Yeah. So like for example, for patients who have type 1 diabetes, the ones whose body is not producing insulin, so we have to give them insulin from outside. Yeah. And the best way of giving that insulin is either using an insulin pump, but which is not widely available, which is quite expensive, and not everybody can get it. So the most common way and one of the best ways of giving it is through 4 different injections. Okay, so it's like 2 injections but given 4 times a day. All right. So those people, or some people are on the mixed insulins, which are given twice a day. So individuals who have type 1 diabetes then need to ideally check their sugars at least 4 to 6 times in a day. Okay, and whenever they are feeling unwell, they need to check. For all patients with diabetes, if you are not feeling well, you need to check your sugars immediately. But generally for type 1 diabetes, we recommend at least 4 to 6 readings in a day. That is before food and at least 1.5 to 2 hours after food, from the start of the food. Okay, for type 2 diabetes, who are only on lifestyle modification, like on diet and exercise only, and they are not on any medication for diabetes, they can actually check their sugars even once or twice a week. Okay, and for those who cannot afford that as well, we tell them to actually check at least once or like at least twice in about 2 weeks. Yeah, one fasting and one sugar. Fasting means after an overnight fast, that means you have not eaten anything, and before your breakfast you have checked your sugar. And those who are on medication, then depending on which medication they are on, we tailor the frequency of checking. Okay, so we usually tell them, at least in the beginning when we start them on medication, when we start patients on medication, we tell you to check fasting sugars and 2 hours after food sugars at least. So that's 4 readings. But with time, if the sugar is well controlled, then we can go down on the frequency to even one reading in a day, then gradually even up to 1 or 2 readings in a week, depending on how well your sugar is
So
controlled.
it varies from type to type?
From type to type, from patient to patient,
patient,
and from
okay.
even affordability is a big a big factor, especially in our setting. You know, some people cannot afford to buy those strips, so we have to really tailor. Then in those individuals, what we advise them is that, especially with type 2 diabetes, is that if you can't do, you know, frequent readings, then what you do is, at least in a month, choose any 3 days where you will check 6 readings, you know, before foods and 2 hours after food. So that ends up being much convenient and much cheaper for them. Then of course gestational diabetes, depending on what medication they are on, the frequency of checking will vary according to that.
Thank you, Dr. But once one is diagnosed to suffer from the diabetes, should one change his diet or maintain the same diet?
No, definitely, depending on again the type of diabetes, but generally overall, when you have diabetes, you need to focus on the diet, because it's like, you know, somebody having asthma, right, and you are allergic to dust, so you will not go in dust, right? You'll avoid going in a dusty environment. So similarly, like that with diabetes, your body is intolerant to sugar, all right? So that means that your body cannot use sugar, right, adequately. So then we try to optimize on reduction of carbohydrates from the diet. You see, your own body does produce glucose as well. Okay, so you really don't need so much of carbohydrates from external sources. Ideally, even up to 50 to 100 grams of carbs is usually enough for our bodies. So what we are focusing on, especially with type 2 diabetes, is a lot of reduction of carbohydrates in their diets, and also caloric modification. Yeah. So that is like moderate quantities of fat. You know, previously we used to really drastically cut down on fat. Now we know that the bigger problem is the carbohydrates rather than the fats. Of course, fats also, you have to be cautious because of weight issues, and you know, sometimes some types of fats you want to avoid in certain situations. But what we know is the carbohydrates even impact on your cholesterol levels overall, okay? So we are focusing more on reducing the carbohydrates, improving on your greens, especially Kenya. We are so blessed, we have all kinds of greens, you know. The local vegetables that we have, the sukuma, managu, spinach, you know, name it, we have it here. We have all kinds of greens, broccoli, you know, all kinds of salads, including the exotic vegetables. I think greens, we have a lot of it. So that is what should constitute quite a lot of our plates generally, even, you know, before you have developed diabetes. But even in patients with diabetes, we advocate for a lot of that, and adequate amounts of proteins in their diet. So to balance the meal, but to reduce the carbohydrate portion, that is what we recommend. So diet, of course, has a big role to play in management of diabetes of any type.
So once you are diagnosed with diabetes and you are on insulin, maybe you're injecting yourself, is this for a lifetime, or maybe after a certain period of time, maybe you can do away with
Insulin.
Yeah.
Good question, yeah. So again, it will be dependent on the type of diabetes, and it is individualized. You know, diabetes management is very individualized. There is nothing like one shoe fits everybody, right? So like for example, patient A, if you have, who is having type 1 diabetes and is on insulin, obviously that's not a patient who will come out of insulin unless they get a pancreatic transplant, which is very difficult to do and not common as well. And you only do it when you are doing a kidney transplant concurrently in most cases, right? And that's not even being done in Kenya anyway. So basically when we are looking at it, it's like type 1 diabetes on insulin will not be able to come out of insulin, obviously. When you look at type 2 diabetes patients who are on insulin, it depends now on how they were put on insulin and what was the indication of starting that insulin. So for example, some patients who have very high sugars and their sugar levels, like the 3-month test is really very high, above 10%, normal being less than, normal like not normal but the target in most patients being less than 6.5% or at least 7%. And if you have your sugars at diagnosis being more than 10%, then these are patients, or they're very high sugars like 20s and above. At diagnosis, we put them on insulin. So those patients, you can easily come out of insulin. So that will be like just a bridging measure. Those ones you can easily get out of insulin. It doesn't mean that if you're put on insulin is for life in that category of patients, right? Then you have another category of patients who have been on, you know, dietary modifications. Then their diabetes progressed. Now they were put on tablets. Now diabetes progressed and they were started on insulin. So let's say about 5 to 10 years of diagnosis, since diagnosis, and these patients have now been put on insulin. If their lifestyle is not appropriate or not optimum, then even these patients, we try to get them back down on insulin as we optimize their lifestyle. The key, especially with type 2 diabetes, is lifestyle modification, because that's where the problem starts, right? So then if those patients are doing well, on their lifestyle and on some tablet forms, nowadays we have a lot of options for tablets as well. So then we can slowly come down on insulin. But if, for example, someone has had diabetes for about 20 years and their body is just not able to produce insulin, because even type 2 diabetes over years, the insulin production keeps going down, especially if they've not had good control early on. Yeah. So those patients, it becomes quite challenging to come down or reverse on insulin. Yeah? So then they might need some form of insulin therapy along with the tablets to maintain their sugars.
Well, you can join the conversation through a social media platform by either dropping a question or a suggestion. Let's take another short break. We'll be back shortly. Assalamu alaikum, welcome back to our third and final segment of the show. If you are joining us, this is Stay Healthy, and today we are talking about diabetes. Daktari, right now we are on the holy month of Ramadan, and if you are diagnosed with diabetes, can one fast?
So fasting and Ramadan, diabetes is actually a very detailed topic which actually every Muslim must be aware of. Yeah. Definitely someone somewhere must be having diabetes nowadays, the way diabetes is so common. So it will help to understand the whole concept of who can and who cannot fast in Ramadan, right, if you have diabetes. So before we go there, what viewers need to understand is that diabetes actually can pose someone who is fasting to serious risk problems, right, to serious risks. And out of that, the most common is low blood sugar. As you can understand that these patients, they are already taking medications, and they therefore have a very high chance of getting hypoglycemia or low blood sugars. Yeah. So that is one of a very severe risk that is associated. You see, our body actually uses, what happens is when we don't eat, so about up to 12 hours, our body produces or breaks down its own stores to give us glucose, to give us energy. But after that, there is no more glycogen stores. So what happens is that the body now starts depending on fat breakdown. So then there is a bit of fat breakdown that takes place, and in the form of ketones is where you get your energy. Okay. But the brain needs glucose only to use energy. So if you don't have diabetes, then the body preserves that little bit of glucose for the brain and your red cells, right? But now in patients who have diabetes, this whole problem, the mechanism doesn't work normally, okay? Your body cannot actually, start breaking down because there's a problem with insulin production generally, or insulin use. So the breakdown of fat is not the same as like in someone who does not have diabetes. So there's a high risk of the sugar going low in these patients. Again, another big risk is the sugars going too high also, okay? Because again, your body, like let's say for suhoor, you have eaten a lot of food, which has a lot of carbohydrates, sugars. Then there's a very high risk of your sugars going too high as well, okay, because your body's capacity to handle this sugar is not as good as normal. So then there's a high chance of getting high blood sugars as well. So the levels can fluctuate. Thirdly, another very high risk is dehydration, because when you have high sugars and poorly controlled sugars especially, then you can get into dehydration when you are fasting. There's a higher risk of dehydration, and the other risk which is actually can be critical is ketoacidosis, especially in type 1 diabetes or in individuals who have diabetes who are on insulin and they're dependent on insulin. So their sugars can actually go really high and can directly precipitate acidosis, especially if they have excessive fat breakdown. Then that changes to acid and they can get diabetic ketoacidosis. Another risk is clot formation. So these are serious risks that can occur in patients with diabetes who fast in the month of Ramadan because of that duration of fasting. However, having said that, There is the International Diabetes Federation in liaison with Diabetes and Ramadan Alliance group have come up, and they have actually had serious discussions and sittings with muftis across the globe, and also with specialists in diabetes, and they've come up with guidelines. And we are blessed, we are in an era where we have those guidelines to actually assess and to guide us on which patients are safe to fast in Ramadan and which patients are not safe. Okay, so what the guidelines have brought in this time, the 2021 update of the guideline, is a risk stratification tool. So actually, if you look online, you can find this DAR, Diabetes and Ramadan risk calculator. So that calculator, you just put in your risk factors. So it will keep on asking you which type of diabetes you have. If it is type 2, your risk is lower than type 1 diabetes, okay, or pregnancy related. How long have you had diabetes? So if you have had diabetes for longer duration than, like, let's say 10 years, your risk is very high to develop complications, those that I mentioned, during fasting. So it gives you a risk, higher risk. What kind of work do you do? If you are a physical laborer, your risk is very high, you see, because you will require energy. So if you are a physical laborer, you are diabetic, and then you are fasting, your risk is high. So the score will tell you accordingly. Again, whether you are pregnant or not, okay. How was your previous Ramadan experience? What is the duration of fasting? Is it more than 16 hours, less than 16 hours? The risk is accordingly classified. Then if you have had complications of diabetes, like acute complications in the last 3 months, let's say someone was admitted because of very high sugars, they are definitely at higher risk of developing high sugars even in Ramadan, right? Again, someone who has complications like kidney problems or cardiac problems, they are at a higher risk than those who don't have such complications. So the calculator will actually do the risk stratification, and then it will put you at either low risk, moderate risk or high risk. So low risk is a score of less than 3, moderate is between 3.5 to 6, and high risk is more than 6. So if it is low risk, both the doctors, that is the medical professionals, and the religious scholars recommend that these individuals should fast, ideally. However, if they are checking their sugars and they see that the sugars are going high or low, or they are feeling unwell, then they should break their fast immediately. And we'll discuss, I think, about when to break the fast. That is also very, very crucial. Then the moderate risk category. This is a risk category where the religious scholars have left it to the doctors to decide on whether a patient can fast or not fast based on their assessment. So these are patients who, if they are intending to fast, we do it with a lot of caution and a lot of care, whereby they need to monitor their sugars very, very closely, which means up to 6 to 7 times a day checking your blood sugars to assess that it's not going too low or it's not going too high. And if they feel even sick a little bit, any kind of illness, whether it's just a flu or any issues, then they should break their fast ideally. So that is the moderate risk category. And then you have the high risk category, whereby the risk score is more than 6. Here both the muftis or the scholars and the doctors recommend that the patients must not fast ideally. So it is not recommended to fast in this risk category. Okay, so that tells us about which patients can or cannot fast in the month of Ramadan if they have diabetes. However, the truth is that even if you are in any risk category and you do decide to fast, you need to, ideally, now we are already in Ramadan, but ideally at least 4 to 6 weeks before Ramadan, you need to see your healthcare providers and discuss your management plan with them and how and when you can break your fast and what is your risk category. But if these people do intend to fast, then we support them in all the ways possible. Like for example, where I work, like at the Diabetes Care Center at Mpisha, we have a full team of specialists where the nutritionist is there, the dietitian, then the diabetes educator is there, who can continuously on a 24-hour basis be supporting these patients on different aspects of diabetes and when to break their fast and all. So you need to be in touch with your healthcare team very closely. But ideally, if your risk score is more than 6, you shouldn't be fasting.
Okay. So once you have checked your risk factors, it's when you can determine either you can go ahead and fast or not. Now, Doctor, you have mentioned about when to break the fast. Can you tell us more about that?
Yeah, so if you have diabetes and you are fasting, regardless of the type of diabetes or regardless of, your risk category, If you see that your sugar is going below 4 millimoles per liter, in our setup we are using millimoles per liter, or 70 milligram per deciliter, if that is the kind of readings that you are using, then you need to break your fast immediately, because that is a very high risk. That means your sugars are going low, you need to eat something. If it is between 4 and 5, you need to check your sugars again after about 15 to 30 minutes and check if they are going lower, then you still need to break your fast, okay? But if your sugars are going above 16, again, that's another category of patients who need to break their fast immediately, okay? Because also that poses a risk of dehydration and also clot formation. Then at any point, if you are feeling unwell, like I mentioned, acute illness, you need to break your fast. Especially nowadays in this COVID era, we are having a lot of patients who may end up having, you know, even mild COVID or, you know, moderate COVID. And those are the patients who need to, the moment you are not feeling well, you need to break your fast, okay? Other than breaking the fast, we discuss a whole lot about change in medication when you are fasting, yeah? And dietary changes. So that is why you need to get that advice pre-hand, yeah? Before Ramadan, to be advised on what kind of diet you should be on and what you should avoid, what you should eat.
So, Dr. any advice to our viewers?
So we are in the blessed month of Ramadan. First of all, to all our viewers, Ramadan Mubarak, Ramadan Kareem to all of you. May this Ramadan pass for us, you know, safely, inshallah, and successfully, and may we achieve the best that we can achieve as far as our ibadah is concerned, and as well as the benefits of fasting are concerned in this month of Ramadan, inshallah. But for those of you who have diabetes and you are right now listening to us and you have not had a pre-Ramadan diabetes education or assessment done, you can still go ahead and do your assessment, or you can contact your healthcare team or healthcare providers, your diabetes specialists or diabetes care centers, and learn more about the risks you are at and how you can be supported during this month of Ramadan and even later on, inshallah.
Daktari, thank you so much. Indeed, it has been a pleasure hosting you on the show. Well, that marks the end of our show today. Join us next week, same time. Many thanks to my production team. I've been your host, Maryam Salim. Till next time, ma'asalam.